All right, everyone, welcome. Today, we're going to build out a clinical playbook for thyroid pharmacotherapy. We're skipping the basic physiology, you already know that. We're jumping straight into the high-yield stuff, the decisions and clinical pearls that really separate a good pharmacist from a great one. Okay, let's just dive right in with a high-stakes scenario. Your patient is crashing, fever, tachycardia, altered mental status. You're thinking thyroid storm. What's the call? PTU or methimazole? And what's your very next move? That decision could be life or death. We're going to come back and solve this, but first, we need to lay down the groundwork for how these drugs work. First up, hypothyroidism. We're going to really focus on mastering the workhorse here, levothyroxine therapy. So, levothyroxine, or T4, it's the standard of care for a reason, right? It's predictable. But that predictability is completely tied to its PK. And honestly, if you understand the pharmacokinetics, every dosing and monitoring decision we're about to talk about just makes sense. Okay, look at this table. These two numbers drive everything. The half-life is about a week. So think about it. 5 half-lives to steady state. That's why we wait 4 to 6 weeks to recheck a TSH. Checking it any sooner, it's a classic mistake, and all you're going to do is chase a meaningless number. Then look at the dose, 1.6 mics per kilo per day. And remember, that's lean body weight. Super important, especially in your obese patients. Otherwise, you're going to push them iatrogenically hyperthyroid. Now, for your high-risk folks, anyone over 60 or with a history of cardiac disease, this isn't just a suggestion, it's a hard rule. You have to start low and go slow. We're talking 12.5 to 25 mics a day. Why? Because if you titrate too aggressively, you crank up their myocardial oxygen demand, and you can literally throw them into AFib or even an MI. This is pure risk mitigation. And here's a special population you absolutely have to get right: pregnancy. As soon as you have a confirmed pregnancy, you need to increase that levothyroxine dose right away. We're talking a 20 to 30% bump, sometimes even up to 50%. You do this to support fetal brain development. If you wait for the TSH to creep up, you're already behind. The key word here is proactive. So a common question is, what about T3, liothyronine? I mean, it's 4 times more potent, right? So why isn't it first line? Well, it all comes down to that half-life. It's less than a day. This creates these wild peaks and valleys in hormone levels, which is really tough on the heart. You get a much higher risk of tachycardia, arrhythmias, things you don't want. So its role is really limited to very specific situations, like IV for mixed edema coma. For pretty much every outpatient, T4 is just the safer, more stable choice. Okay, let's talk practical pearls. Absorption is key. It has to be taken on an empty stomach, 30 to 60 minutes before food. That's non-negotiable. And here's a pro tip. If you have a patient who is stable and their TSH suddenly shoots up, don't just assume non-adherence. Ask them, did you start taking a multivitamin, an iron pill, a calcium supplement? Those cations are notorious for binding it up. You need a 4-hour separation, period. And one more thing, don't forget the warfarin interaction. Levo chews up clotting factors, so you'll see that INR rise. You've got to monitor it closely when you're starting or titrating. All right, let's switch gears. We're moving on to hyperthyroidism and thiamide therapy. Now, unlike with hypo, where levothyroxine is king, here you've got a choice to make between PTU and methimazole. This table right here, this is basically your decision-making cheat sheet. For your standard outpatient with Graves' disease, methimazole is almost always the answer. Why? Once daily dosing. It's just so much better for adherence. But, and this is a big but, PTU has 2 critical can't-miss indications. Number 1, first trimester of pregnancy. Methimazole is teratogenic. Number 2, thyroid storm. And that's because PTU has a special trick up its sleeve. It blocks the peripheral conversion of T4 to the more active T3. Methimazole can't do that. Okay, now for the scary stuff. We have to talk about the high-alert adverse effects of the thioamides. These are rare, but they are true medical emergencies, and your counseling is the patient's first and best line of defense. A granulocytosis. This is the one we all worry about. It's a catastrophic drop in neutrophils, your main infection-fighting white blood cells. It's rare, maybe happens in 0.5% of patients, usually in the first 3 months. But when it happens, you've essentially stripped the patient of their immune system, leaving them wide open to life-threatening infections. So your counseling here has to be crystal clear. You tell the patient, if you get a fever, if you get a sore throat that won't go away, you stop this medication immediately and you go to the emergency room. No exceptions. They need a stat CBC with a differential to check their absolute neutrophil count. This isn't something to wait on. Early detection is everything. The other big one is hepatotoxicity. PTU even has a black box warning for it. So if your patient develops jaundice, dark urine, or their LFTs go through the roof, you obviously stop the drug. But here's the key clinical point. You can't just switch them to the other thioamide. The risk of cross-reactivity is too high. Thioamide-induced hepatitis means the entire class is now contraindicated for that patient. All right, let's circle back to that patient we started with, the one who's crashing in thyroid storm. Now that we've covered the pharmacology, we can actually solve the case. And in a crisis like this, the sequence of what you give is absolutely everything. This sequence is non-negotiable. It's an unbreakable rule. Step 1, you give a thioamide. And PTU is preferred, remember, because it blocks peripheral conversion. This stops the factory from making new hormone. Step 2, you wait. You have to wait at least 1 full hour. Why? Because if you give iodide right away, you're just throwing more fuel on the fire. Iodide is the raw material for thyroid hormone. You'd actually make the storm worse. So you block synthesis first, then you give iodide to block the release of all the hormone that's already been made and stored up. Get that order wrong, and you've made a massive clinical error. Okay, let's wrap this up and distill everything we've talked about into your clinical playbook. These are the top 5 rules you need to know. So here it is, your 5 big take-homes. Number 1, for levothyroxine, start low and go slow in your cardiac and elderly patients. Number 2, in pregnancy, you do the opposite. You proactively bump that levo dose up, and if they're hyperthyroid, it's PTU in the first trimester. 3, for your everyday hyperthyroid patient, methimazole is your go-to, thanks to that once-daily dosing. 4, thyroidamine adverse effects. Fever plus sore throat equals a trip to the ER for a stat CBC. Jaundice means you stop the drug, and you do not switch to the other one. And finally, number 5, thyroid storm. The order is sacred. Thyroidamide first, then wait an hour, then iodide. Got it? And I'll leave you with one final thought problem here, just to test the nuance. Your patient on methimazole calls. They've got a simple, mild rash. It's a little itchy, but that's it. No fever, no sore throat, no systemic symptoms. So, it's not agranulocytosis, it's not hepatitis. What's your next step? Think on that one. Thanks for joining me.